Well, why don't we get started this morning? Thanks to all of our program directors for joining this morning. As we mentioned last month, we're doing a series of quality and patient safety talks this year to further engage all of you in the work that's happening on the clinical front in our hospitals. And we really want program directors to have much deeper understanding in quality and patient safety principles and work so that you can help mentor and guide your trainees. And so really happy to have two more presenters today. Dr. Catherine Chen is the Associate Vice Chair of Quality and Safety in the RWJMS Department of Medicine and runs their QI curriculum within the residency program. And Brian Baker is the Director of Quality Resource Services and is based at Monmouth Medical Center. And so thanks to both of you, and I'll turn it over.
All right, thanks, Neil. So today we're going to be talking about quality tools and starting with our safety story. So this may be familiar to some of you, or if not, then maybe you've heard of something similar to this, but this is the insulin to needle mismatch issue that keeps popping up with some frequency in our EDs. And I do see some of our endocrinologists on here, so I'm sure you can put things in the chat. But so in this story, she's 33 years old, no significant past medical history, comes in with blurry vision, frequent urination, thinking she has a UTI. Instead, she has extremely high glucose, some metabolic acidosis, and a small anion gap. She has lots of glucose and no nitrites in her urine, a little bit of ketones. So in the ED, she started on some sub-Q insulin, and then it looks like it's well controlled. So they discharge her and prescribe her some 10 units of Lantus to be given nightly. She returns to the ED 3 days later in florid DKA with a larger anion gap and a glucose of 550, and she's admitted to the ICU. She said she picked up her insulin, but she couldn't figure out how to use it. She got apparently a 32 gauge 4 mm needle prescribed with a vial of insulin glargine. So I guess in the normally I think we would have tried to do a poll, but that was not successful this morning. So any of you who have access who are not driving or anything like that, um, put in the chat like whether this has happened to you, whether you've accidentally done it, if you've seen your residents do it and then had to field some calls by pharmacy, or if you've handled the aftermath of this error, if you've been the one to receive this in the ICU or in the ED or on the floors, um, whether this has never happened to you. That also we'd like to hear this as well. Yeah, I feel like pediatrics, that that may happen with lots of type 1s perhaps, but Polly says that she has not had that happen yet. If you feel super enthusiastic about it, you're welcome to also unmute. We'll give it a few seconds. All right, so with the safety story, there's there's a lot of things that happen, right? So we'll talk through some of those using this as an example. I'm going to turn it over to Brian to talk about how we use these tools to, or use some QI tools to break down this issue.
Thanks, Dr. Chen. So whenever we have a problem, whether it's through a safety event that we identify or just in identifying flaws in processes, there's several different tools that we're able to use. Two main ones that are commonly used are the PDSA cycle and DMAIC, which is a Six Sigma tool. PDSA is something that my team uses more often. It was developed by Walter Schuhart and W.E. Deming back in the early 1900s. It was used in manufacturing and has been adapted for process improvement more generally, including in healthcare. And it really provides a framework for how to follow a structured process to make changes in a way that you can identify whether or not those changes are working, and that you can easily adapt to make additional changes if necessary, if your changes aren't working. So the cycle on the left is going clockwise. You see the arrows there. The Six Sigma model on the right is similar. It moves counterclockwise, so that's the order there. It's DMAIC going counterclockwise. And if you go to the next slide, Dr. Chen, talk about the PDSA cycle. So specifically looking at the issue that we're having here. The plan part is where you want to plan what the test you want to do is. You want to figure out how you're collecting data. You always want to have a question that you want to answer and make a prediction about what you think would happen, develop a plan to test the change, and then identify what you need to collect. So, for example, in this case, our issue here is with patients coming back into the hospital after being in the hospital for a diabetic issue. So why is this happening? And one of the things that is identified in this case is that they're not compliant with meds. One of the tools that we use is 5 whys and trying to identify root causes. So in this case, we would keep going down that rabbit hole of asking questions. Why isn't the patient compliant with meds? The patient is, unable to use the medication that was prescribed because of why are they unable to use it? Because there was a mismatch between the needle and the vial. So that's our problem. That's the baseline of what we want to work on. We'll talk a little later about what a SMART goal is, but this would have been preceded by creating a SMART goal and developing that in the planning stage. So we want to develop a plan that might change that. So maybe we identify through conversation with the patient and some chart reviews that there could be a potential issue with the patient understanding how to use the pen. We've seen that in the past too, where they had the correct pen, but they weren't using it. So, that would be the do section. So we decide that maybe we want to implement a teach back and return demonstration initiative to make sure that patients are understanding how to use their pens. So we would run that test on a small scale, carry out the test, document any problems and unexpected observations, and then we would collect that data and begin to analyze it. The next step would be the study section. And in the study section, we're analyzing the results and comparing them to what our predictions were. You do it as a team, and you want to make sure that you're involving everybody in this process. I should have said that from the start. You always want your frontline team to be a key participant in any of these cycles, because without them, you're not going to have the best changes and the best goal, even, because they're the ones who do this on a day-to-day basis and know what the potential barriers are. So you could, including them can help you avoid those barriers right off the bat. So when we're studying, we're saying, what are the results saying? Are we seeing maybe a decrease in diabetic readmissions, if that's what you want to look at? Maybe you want to look at the incident of reported failures to use the medication appropriately after discharge, depending on what data you have and what data you're collecting. And then the last part is acting. So you're going to look at what you're seeing from the study part, and you're going to make a plan for the next step. So if we're looking at diabetic readmissions and we say, yes, there was a decrease in diabetic readmissions, that's good, but are there other opportunities that we might have that we can also start another cycle for, to see if we could drive that down even more? That's one thing. And then the next thing would be, if there wasn't a change that was effective, what did we miss? And then we're going to go back and start with a new plan. And then the cycle just keeps going, and there could be, we've seen projects with 15 cycles, we've seen projects with 1 successful cycle. So it's a very adaptable tool, and it's a structured way to make sure that you're proceeding through the change in a way that is both effective and meaningful. Next slide. So this is these are the 6 domains of healthcare quality. This was actually developed by the Institute of Medicine, which I think is now the National Academy of Medicine, back in the early 2000s. And it's really what drives quality work throughout CMS, the other public reporting quality programs all use some version of these different domains in the measures that they look at. So you have the safe domain, where you're avoiding harm to patients from care that is intended to help, being timely, reducing waits and harmful delays, and reducing delays for care providers. The effective care, providing services based on scientific knowledges, using best practices, refraining from providing services that are not likely to benefit patients, avoiding over and underuse or misuse. The second E is efficiency, avoiding waste, including equipment, supplies, ideas, and energy. Equitable, the care doesn't account for personal characteristics such as gender, ethnicity, geographic location, or socioeconomic status. And then patient-centered, providing care that is respectful of and responsive to individual patient preferences, needs, and values, and ensuring that patient values guide all clinical decisions. So the next slide, I'll pass over to Dr. Chen, and she's going to talk about the broad range of tools. And this is just a snapshot of it, all the different tools that we have based on our needs in doing our improvement work.
Thanks,
Oh,
Brian.
okay.
So, yeah, as per usual. So in each of these, we're only going to talk about a snippet, the ones that we've highlighted here. But in each of the sections, this is based more on the DMAIC model. You have different tools that you can use. So in defining the problem, you can either start from the issue that happened and doing cause and effect, like what happened and why did that happen. You can figure out if it's like a process issue, that there's like a process that's inefficient. You can use a process map, so we'll also talk about that. There's also something called the driver diagram that you may hear about, and that is actually starting with what you want, so your desired outcome, and then working backwards. What gives you that desired outcome? Great patient care. Well, it needs to be timely, it needs to be all those steep like all those steep domains, and so that would kind of be like an example of a driver diagram that you could draft out for an issue. And then this is the define domain is to just identify factors that hinder quality of care. In measuring, you can use any, using some tools that help you determine if the goal is quantifiable, to make sure that you can actually get data on it, and that the data, preferentially is not super reliant on manual and subjective sources. So hopefully you can like call that from the Epic, or draft it somehow that does not rely on human, introduce an additional layer of human error. We talked about the steep paradigm there. And then in analyze, you can use just basically making sure you have effective resource utilization, taking all the data that you can get, and then deciding like what kind of is the most effective route that we can take in terms of developing a plan. So we'll talk a little bit about the 80-20 rule, or the Pareto principle. And this is essentially using what data you have to determine how you can optimize the resources. And then you can evaluate also process outcomes, and there's also something called the failure modes and effect analysis, where as you develop the plan, you think about, okay, well, what could go wrong with this plan? And how severe would it be if this thing was to go wrong? Is it like a high frequency, low severity thing, or is it a low severity, low frequency, very severe thing? Like if the outcome was morbidity, for example. And so thinking about some of these things in advance helps you to refine your plan before implementation, to, kind of pre-mortem the issues. So improving, you obviously, like what Ryan said, getting the team to buy in, making sure that your team is well represented, and then developing a really solid, SMART goal with well-defined parameters. And then in the control portion, we want to be able to iterate on it. So, getting that data and being able to monitor it over time with enough resolution to make sure that you can keep raising the standards. And if things don't work out, what are those causes and how can we decrease those? And this is really good for accountability, transparency, and being able to communicate back to your team and also to the broader organization what's happening in terms of your improvement project. So, going to talk a little bit about first thing, Fishbone. Many of you are very familiar with this. This happens to be the Fishbone that was drafted last year from the IM residents as we were talking about this specific patient safety issue. And the head of the fish is the issue itself. So in this case, insulin pen vial order mismatch. And then the kind of main spines of the fish, those bigger ones, here we've said human factors, communication, patient factors, heuristics, and systems factors. There are lots of different spines that you can use. Some fishes have multiple fish, yeah, have lots of spines. Some of them have only a few. And if you have more of a process spine, maybe there's like a few breakdown of like the systems based processes. But so these kind of major categories can be a little bit interchangeable, or you can switch it up for your purpose. But having some broader categorizations of the issues that arise and the causes of those issues is what we're looking for there. And then on those spines, there's like smaller spines, and those are the actual kind of issues that arose, like the problems in this specific case. So for human factors, they identified that we put in the incorrect order. So in this case, possibly a knowledge issue or an oversight issue, and there may have been some also heuristic reliance on pharmacists to clarify orders. We rely on our pharmacists a lot, so maybe we're thinking like, oh yeah, I'll just send it to pharmacy and like pharmacy will fix it for me. That may or may not be the case. In this case, that did not happen because she got two clearly different items. Some other heuristic factors, we didn't realize or remember that the patient is a first-time insulin user, and so receiving these items, they may not realize that this is not the right pairing. Yeah, here is assuming that pharmacy will catch all of these things because they catch everything. Things that are patient factors, well, she's a first-time insulin user, and really we can't say that we've provided the correct education for her to be able to support her in that. Structural factors here, or systemic factors, there's not an order set that is specifically for insulin prescribing in this case. We're not monitoring the patients that are not able to follow up. So sometimes maybe like a transition of care program, making sure that they get to endocrine or that they have received the medications from pharmacy. We don't actually really usually think about what kind of insurances do and do not cover the types of insulin that we have available, the oodles of types of insulin that we have available. And there's not an alert in Epic to say like, hey, did you really mean to order a vial and a pen together? Like that doesn't seem right. So that doesn't exist. And then also, it may have been an odd hour. We didn't specify, but diabetic education may not be available uniformly throughout the day. And so if she's discharged perhaps late at night or on the weekends, that might not have been available. And then for communication factors, things like nursing, counseling on insulin use may be variable. It may depend on what the doctors have, checked off in patient pass to give to the patient. And once the provider leaves the ED, like the prescription's in the pharmacy and the pharmacy calls, what happens to that? Does it get routed to a covering provider who's like, this is not my patient, or is there some kind of process whereby we can get the answers for the pharmacy in a timely fashion? So this is kind of like the generic fishbone. You can certainly get into it very deeply, and each of those little spines can have further little spines. But building off of that, this is the process map. So we decided that, okay, there's something going on in our process that we need to figure out. So what happens to our patients when they hit the door, or when we're first deciding to finish treatment and discharge them? Well, in the discharge planning phase, this is just kind of a mock-up of that. The process map says that the discharge planning phase includes diabetes education on insulin use and hyperglycemic management. Great. We say probably would provide that. And then we prescribe the discharge medications incorrectly in this phase. And so what happens when the patient goes to when it's like in the hands of the patient, she goes to pick up the medications from pharmacy. There's two options. One, the pharmacy recognizes that it's not correct and gives a call back to the hospital. The other one is they get dispensed the medications incorrectly, as in this case. So if the pharmacy decides to call back the hospital, can we reach the provider for medication or needle clarification? If yes, then it's clarified and dispensed correctly. If no, then the medication or needles are not dispensed, and the patient gets one, both, or either, or neither of these things. And then it becomes back to the patient's bucket to have them call the provider and see if they can reach the patient, if they can reach the ED provider somehow. So if they can, then it goes back into this process of being able to reach the provider. If they cannot, then and if the medication is dispensed incorrectly, then they'll come back to the ER with their subsequent hyperglycemic episode. So these things can get pretty convoluted. There's an upgrade of this version called the swim lanes, where it's everybody, every role has their own like task alignment. So I kind of generically put it here in discharge planning, patient management, and pharmacy. But you can get pretty elaborate with these as the projects get bigger and more people are involved. So I put the little legend at the bottom, which I probably should have talked about earlier, but the blue blocks here are the process steps themselves. The orange is the any delays that happen, and then the diamonds are the decision points. So if things are happening that kind of yes, no, or multiple branches can happen, that's you can use that as the legend. And these legends are just define a legend. It really doesn't matter what the shapes are. All right, and then taking these issues from the process mapping and the fishbone, you can kind of quantify them. If you look into, for example, like a set of cases that happened in your ER, you can say like what happened to this patient and that patient and the other patient. Oh, well, 50% of the time it's because we prescribed it wrong. 30% of the time it's because this happened. 20% of the time it's because that happened. And when you begin to quantify some of these causes, you can get an idea of some things that are high frequency and some things that are much lower in frequency. And that's where you want to put your resources, right? So this is kind of like the pretest probability. I want to do the things that are most efficacious. So I'm going to try and put my efforts to reduce the things that happen 50, 60, 80% of the time. So 100% of the time we've prescribed it incorrectly, which is why they received the wrong information, the wrong medications. So we would want to address that. But also subsequent to that, like, is there a provider callback? We received X number of provider callbacks, but we only are able to answer 10% of them. Well, that is something that we might want to address. So taking some of these high priority items can help narrow down our focus and help us develop more of an outcomes-based process improvement. And this also helps resource utilization because we don't have infinite resources. It would be nice if we can fix everything down to like the most minuscule problem and the most rare occurrence, but we just can't. And so, how do we make sure to capture the most people and the most errors as possible in building our Swiss cheese? All right, and so I'm going to turn it back over to Brian to talk about the SMART aims.
Thanks. And just before I talk about SMART aims, I just wanted to mention with the process maps, it's really important to involve the people who are actually involved in the process. It's really, really important. A lot of times, especially at an administration level, you think you know what's happening, but when you get the people involved, they say, no, that's not what happens at all. So it's really important to make sure you're involving them to have a good process map so that you know where to start. And, I think one of the best practices when doing this is to do it either on a whiteboard or a giant sheet of paper with a pencil where you could erase constantly because it's going to change many times. So that the pretty process map we had there on that slide is the result of probably many different iterations. So just something to think about. So any project that we're working on, and even more broadly outside of the performance improvement quality realm, we're using SMART aims all the time now, or SMART goals. So when you have a goal, you want it to be specific. It should be clear and well defined. It should answer questions like, what do we want to achieve and who's going to do it? We want it to be measurable. We want to make sure that whatever our goal is, it's something that we can actually measure and that we have the data and the indicators to be able to identify that how we're doing. We want it to be achievable. It should be realistic and attainable. You got to take into account the resources that you have and the skills that your team has, as well, as Dr. Chen alluded to. Then it has to be relevant. A lot of times people start making goals for one problem, and then they end up kind of taking on a different problem, I guess. So you want to make sure it aligns. You want to make sure it aligns with the broader objectives of your department, your hospital overall, patient care, and then being time bound is really important, because you want to make sure you have a definitive end by which you want to say, I either met my goal or I didn't meet my goal. So that's really important. I'm just reading Emily's note here. What's your advice on avoiding the pull of making the SMART aim retrospectively so that you make it once you do it? So yes, this does happen. My advice is to involve your quality team so that they could guide you on how to follow the correct steps in the process. And also make sure that the whole team's involved from the beginning so that you could create your SMART goal together, and actually follow the structured process of doing a quality project. This is a result of somebody coming up with a good idea, doing the work, and then looking back and saying, we want to make this an official quality project. A lot of times this is what we see. It's a good question, Emily. So if we're looking at SMART goals in the context of the problem that we were talking about, there's a great SMART goal here for creating an EPIC order set for the emergency department and inpatient use with paired insulin and needle orders and general insurance guidelines, and educate providers on use to reduce insulin needle mismatch by 70% within 3 months of implementation. The most common thing I see missed in a SMART goal is having the time frame. And that's something we always kick back to residents. We say, this is a good goal, but you don't say when you want it to be done by. So that's a SMART aim. Next slide. So we made our SMART aims. We're following our PDSA or DMAIC, DMAIC cycles. And then we're starting to collect data. There's different ways we look at data. Run chart is a very common one. This is often what we use in the beginning of a project. It's made for smaller data sets. It helps you identify shifts or runs or trends or clusters. And it's just basically a plot over time. If you go to the next slide. What we like to use, especially when analyzing results of a project, is control charts, and that's used for larger data sets. It's kind of an extension of the capabilities of a run chart. We have special analytic tools in Excel that help us make these charts, and it helps identify different control limits and the process average. The big value of having a control chart is it helps identifies common cause variations versus special cause variations. So you can see that outlier in this one slide over here to the left, where there's a low measure that's below the lower control limit. That means you got to look into that and see is it a one-off, or is there something big going on that we need to look at during that time. I commonly see this in fall events and restraint event data when I'm looking at it. because there might be one patient who's here in that month, and we end up having much more falls or restraints due to a challenge specific to that individual. Next slide. This is just an example of a control chart that I had made for a project we did reducing falls. And what I wanted to show here is that you can really show a lot just with one slide. You see the falls data rate over time. You could see we identify when each PDSA cycle or change was made here on the timeline by these rectangular boxes. And you could also see whether or not any of the data points went out of control, which they did not. And as a result of this project, it extended out. We actually had 3 years of consecutive 15% reduction of inpatient falls. Next slide.
All right. So, tying this all together, how do you use these tools for our residents and fellows? I think, if you have a resident and fellow who comes to you and says that they want to affect change, you can kind of give them some of these tools in the toolkit, and just point them to different tools for their purpose, right? So if they're thinking like, oh, I have a process inefficiency, you can point them towards process mapping. If it's a root cause issue, you can point them towards a fishbone. Or if they're at the point where they, want to think about what kind of data they need, well, maybe it's time to introduce them to a SMART goal just for any goal setting purposes. And you can also use it in everyday life. So whether that's for your own process improvements in your programs or triaging resident issues, you can also use SMART goals and QI tools in any or all of those settings as well. We like to think of it as a slippery slope. If you start using it, then eventually you'll end up in a QI project. All right. So for the insulin story, though, unfortunately, ours is still in process. Our chief resident last year or this year created a order set last year, and it was reviewed and approved by the Diabetes Management Committee at RWJUH. It was submitted for EPIC enhancements and is very slowly, as of the last 6 months, making its way through the EPIC governance structure. So if you, this is part of our PDSA perhaps, if you have this issue at your facility and you are on a Barnabas Health, track, you can submit an EPIC request as well, just to say that, hey, there is such an insulin order set that's out there. It's percolating. Can we speed it up? We would welcome that. Just, putting it out there. And then I think I'll let Neil talk about the rest of the program director curriculum for the rest of the year.
Thanks so
everyone.
much thanks so much to both of you. Really appreciate it. So this was our second of our series, and it was fantastic. So thanks to both of you for this presentation. We are recording it. It will be available on the GME website for reference later on. I think there was a lot of great information in there. And I saw in the chat, I'm not sure which program director it was because they're labeled as iPhone, but one of the program directors is going to upload some of their own program materials onto Teams. And so I think there is a lot of good work that's happening in the programs, and we do want to align with these very helpful QI tools. The next in our series is going to be on November 21 on event reporting and learning from events. And I think there's a lot happening on that front. In particular, we are moving forward in changing from Verge to a new platform run by Press Ganey. And so I think you'll hear about that as part of the discussion on event reporting on November 21. But before all the program directors sign off, we are actually having another 30-minute presentation next month in October prior to the GMAC meeting. And it's going to be specifically on managing residents with problems. So understanding the specific processes now codified through our Rutgers Health policies around remediation, probation, non-renewals, what the appeals process looks like. All of you from time to time, unfortunately, have to get involved in these kinds of situations, and we get tripped up if we're not following policy correctly. And so while we have revised policies, and actually we're revising some of them today for consideration by GMAC, I think it's really important to actually walk all of you through the actual procedures involved when you are working with a resident who's having a particular issue. So that's going to come up next month, I believe, by Dr. Kelly, who has done a lot of the formative work in drafting these policies. That's it for our program director development this morning. So thank you again to Catherine and to Brian. Really appreciate it. And this series, again, will pick up in November before the next GMAC. So thank you again. For those who would like to stay on for the regular GMAC meeting, even if you're not a voting member, you're absolutely welcome. You can certainly stay on. It's an open, transparent meeting that we have here. But if you do want to log off, now would be your opportunity to log off, and we will see you next month for a 30-minute development on, again, a review of all of those procedures and on how to manage residents who are having difficult issues.